Hello, everyone. This is Mark Plaster, Senior Executive Editor of Emergency Physicians Monthly, and you're listening to EP Talk, the place where real emergency physicians come to talk about things that are important to us, our professional lives as well as our personal lives. And today, it is my absolute pleasure to have Elizabeth Clayborne, actually one of my colleagues. She is the Assistant Professor of Emergency Medicine with the University of Maryland group that I practice with, though she practices at a much higher acuity facility in Prince George's County. So welcome, Elizabeth. We're going to get to talk about something that today is really near and dear to my heart, which is moms practicing emergency medicine, which I find to be an incredible challenge. By the way, the reason why I'm not my normal location is because right now I'm in Virginia Beach, and my daughter, who is a labor and delivery nurse, and her husband, who is a emergency medicine resident, are expecting their third child, and we're on baby watch. She's ready to deliver at any moment, and so we're sitting down here waiting. We're taking care of the other two children, and and they're out at the beach today, hoping and praying, keeping our fingers crossed that she actually goes into labor today. But we want to talk about, Liz, I want to talk about your experience practicing as a emergency physician and going through all the physical and emotional and problems of having a family. I don't think most of us guys really can appreciate what you're going through.
Well, thanks for having me, Mark, and congratulations on expecting another grandchild to the family. It's always exciting. I know it's kind of scary times for any pregnant mom to be pregnant during this pandemic. And it certainly was a scary time for me to be pregnant. Practicing as an emergency physician in general is tough, but it was especially stressful to do it in the era of COVID-19.
Yeah.
So, you know, for me, I appreciate that you are insightful to know as a man that you guys probably don't get it.
No,
I'm happy to glean some insight to what it means to be a practicing physician, and, you know, particularly a practicing emergency physician. So, you know, being an ER doc, I think most of us know that we signed up to be exposed to a lot of things, to have grueling hours, to, you know, be frontline in the sense that we are the first people to see folks when they come in and they're undifferentiated. They could be very sick. And a lot of what we do is physically and emotionally demanding. And so just at baseline, I think our jobs are tough. That's why we have a lot of burnout in emergency medicine. That's why, you know, for sites like where I work at Prince George's Hospital Center, you see younger docs there because you just can't do it for a long period of time. It just takes a lot out of you. And so as a mother and someone who's been pregnant twice while practicing, it's especially, you know, demanding. So when you first get pregnant, part of what you have is a lot of fear and anxiety that what you're doing is going to disrupt your pregnancy, and you might have a miscarriage, or that you're really just not allowing yourself to have the time and space to grow a baby in a healthy way, because everything that we do in emergency medicine is not necessarily great for a pregnant mom. So the hours that we work, not awesome. Like there's a lot of studies that show that night shifts lead to preterm labor and miscarriage. And so that's why there's some guidelines now that towards the end of pregnancy, pregnant moms get taken off night shifts to help prevent that risk. And in addition to that, just the number of hours I work. So a lot of, you know, docs are working 8, 9, 10, 12-hour shifts. And so working for that long period of time where you get minimal breaks to eat or use the bathroom is not great. And so as you get more pregnant, small things like being able to drink water regularly, being able to get up and go to the bathroom when you need to, those are things that you really cannot do. Like if someone needs to get intubated, it's not like I gotta go use the bathroom first, hold on. So that makes it challenging.
I don't know. I thought I didn't know what it was like. Now I really know. I don't know what it's like. This is crazy. And
then to layer with that, with COVID, having all the PPE on was just really nuts, because now you're, you know, I was about 7 months pregnant when the pandemic first hit. And so when we started wearing full PPE, because we had such a large number of positive patients or people who we call patients under investigation who we had to gear up for, having a respirator or an N95 mask on with, a face shield, a gown, and everything while you're trying to like breathe with your reduced lung capacity is tough. And you'd get tired and I'd be like panting, and then people would be looking at me like, what are you doing? Why are you even here? And so, there's a lot of that physical stress. But I think in addition to that, there's a lot of emotional stress because you feel really torn when you're a mother. And this is probably true for most professional mothers, right?
Yeah.
A lot of us have worked very hard our whole lives to educate ourselves and to get as far as we have in our careers. And we're very cognizant when we become pregnant that that is going to interrupt that flow, no matter what we do.
Yeah.
And I feel that it's a blessing and a curse, in that it's something that it was super important to my life, that I was so happy when I first, got pregnant the first time, and then even with my second child to be adding and growing my family. But I was also aware that, like, it was going to mean that I was going to have to take time away from work, that I was going to have a whole nother year of pumping and trying to, breastfeed this kid, which interrupts a lot of different things. And that you really just cannot be as aggressive in pursuing things in your career. When you get pregnant, you have to reprioritize. And a lot of times for women, that burden and responsibility of child rearing and kind of being the primary caretaker, especially when they're young, falls on your shoulders, and you're just expected to kind of lift everything up at one time and maintain that professional stamina. And it's challenging.
I hope you had help at home. Surely you had help, right?
Yes, absolutely. I think I was way more fortunate than the vast majority of moms. I have a live-in nanny,
Uh-huh.
which, to be honest, I don't even know how other EM docs that don't have a live-in nanny function, because daycare doesn't work for us, right? If I have an evening shift or a night shift, the daycare is not open. And then if you have a spouse that is, working or travels or does something else, it is impossible to,
Right.
care for kids and still go to work. So fortunately, I have a wonderful live-in nanny who allowed me to continue, working the way that I wanted. And I didn't have any, issues with going to work. And I trusted her, right, to take care of my kids. That's the other thing. I had solid care. And then I have family support. My parents moved to Maryland when I had my first child, which is not uncommon. I'm the eldest of four girls, and they were
Yep.
going to be there for the grandbaby. So having that familial support, and also, the support with childcare, is instrumental to making it work. Because otherwise, I honestly probably would have had to drop down to part-time or PRN. There's just absolutely no way you can
Yeah.
keep practicing once you have, a young child that you're trying to take care of.
My daughter. I can only relate to my daughter, whose husband is going through emergency medicine residency. They had their first child when he was in medical school at the University of Maryland, and you know how time consuming and stressful that is. And during that time period, she was working as a labor delivery nurse, and so it fell to I won't say me, because I was obviously busy with other things, but it fell to my wife, to drive to Baltimore from Annapolis 3-4 times a week, and then had with others dropping in to help fill the gaps and such. And then they came down to Virginia Beach, and now they had two in Baltimore, and number three here is coming in at the end of his residency here in Virginia Beach. And we got down here yesterday, and we walked in the door, and she's conked out on the bed. I mean, she's exhausted.
Right.
Exhausted, and was really excited to have the cavalry show up, and her mom show up and start
Right.
taking care of the kids, and fixing meals, and doing all this other kind of stuff, and allow her to. And it was really interesting. We hugged and kissed, and she went right to sleep. It was the first time.
Yes.
It was the first time she had allowed herself to really relax and
Hmm.
just sleep until she needed to wake up, because she knew everything else the kids were safe, and her husband JD was at the hospital, and when he got home, he had other things he had to do, so it was just having somebody, like you say, live-in nanny. Wow, that's perfect. But you and I both know that that's not the case for a lot of people. uh,
Hmm.
Thank goodness
Yeah,
that
and I think
spiritual allows it, but a lot of people don't have that experience.
Absolutely. And there's single moms. I honestly, this whole process of having a second child makes me say kudos to any single parent, because I have no idea how they do it
Yeah.
while they're chasing around after other kids. And the sleep deprivation and the fatigue, right? Being pregnant makes you extremely tired. Sometimes a lot in the kind of first trimester and then in the second trimester. And so if you're working and then you get home and you have another full-time job to tend to a child,
Right.
that makes it really tough, because as you know, in the ER, we're kind of like on 10 sometimes as soon as we get there. So it's not like a job where you get some breaks, even small things like putting your feet up, right? Like I would have to wear really
Right.
quality compression stockings
Yeah.
throughout my shifts, just so that I wouldn't be huge and edematous and in pain by the time of I got home, because I knew when I got home, it wasn't like I was going to kick my feet up and be able to relax. I was going to start running around after, my like 17-month-old at the time. So, I'm so glad that you wanted to talk about this, because I do think that some of the important things that, like, talking about pregnant moms and docs in particular brings up is that I believe that becoming a mother has really strengthened me as a physician. Just the
Yeah.
insight that I have to other parents, to kids themselves, the way that I can interact with parents and understand what they're going through when I'm taking care of, a loved one in the emergency room is, tenfold since I've become a mother. And I think particularly even for women, like it's just a lot
Yeah.
easier to identify and be able to care and have that insight to care for someone to the best of your abilities when you can identify with their experience. So that has been amazing. But I do think that we're a little behind the times when it comes to supporting, mothers in a professional setting. So my maternity leave was like always kind of a bit of a battle. And I think that this is something that has been a challenge for men to understand, because they don't really get how much that recovery is important. Like you mentioned when you saw, your daughter, like how exhausted she is. I mean, that is, after this baby comes, be prepared to be there to serve her hand and foot, because it's even more important. And that
Yeah.
time immediately following birth is so crucial, right? To the infant's development, to the mother's recovery. There's just a lot of stress, right? There's stress on the mom physically and then emotionally. There's the risk of kind of mental health issues that can creep up in this time. And in this country, we don't really support moms with maternity leave the way they do in other developed nations. So that usually falls on, whatever your employer agreement is. And I find in medicine, even though we're docs and we tell people
That's
to do
right.
these things all the time, we are the worst when it comes to following those same guidelines for
Yeah.
ourselves. So,
Yeah.
for example, during my maternity leave, we didn't have a great benefit. Like we are protected federally through FMLA in that we don't lose our jobs, which used to be a problem for women, right? They would lose their job when they would stop working and have to take 12 weeks off after birth to care for their baby until it was old enough that they could return to work. But now I still feel like there's a financial strain, right? I take such a financial hit when I'm on break. So right now I'm on maternity leave, but I had to go out early because of COVID. I went out around 34 weeks because I was at risk for preterm labor. And the new ACOG guidelines were asking moms to stop working at 36 weeks so that you would not be COVID positive when you delivered. And
Right.
so that time is off, plus the time after the infant. And I only really get supported until recently through short-term disability policies, plus whatever your employer gives her. And I think we're changing, like the tides are turning, and that some of my friends are getting great support. They get like 100% of their pay for 6 months at some places. That's like amazing. And that
Right.
makes it wonderful, because then you feel like, in addition to all the stresses you're dealing with, at least financially, you're okay. But for lots of moms, you have the physical, emotional, and just the mental stress of being a mom, plus the financial pressure of
Right.
not having money to support your family during that time. In this day and age, most households need both incomes of parents if they're together, or the mom might even be on her own, which
Right.
makes it nearly impossible to support kids. So I feel like I never paid attention to this issue of maternity leave
Yeah.
ever,
Yeah. No.
really,
No. I
until
get.
I had a kid. And I'm like, this is so essential. It's essential to the fabric of our nation, supporting families in their most vulnerable moments. And childbirth is one of those times. So, I actually spoke to my group, our group, and they made some changes after I brought up that we had a pretty inadequate maternity leave policy, and they strengthened this financial support that we get after maternity leave. And I cannot tell you, I get emails all the time from my fellow coworkers who are like, "Oh, Liz, I heard that you talked to the group and they're changing our maternity leave policy, and it's so wonderful. I feel so much less stress now that I have that financial support." And it's great that we can do that, but a lot of EM groups are just not financially in the place that they can do that. Like, they're small. It puts too much stress on their
They can
staffing.
they can always do that.
I agree, but it definitely makes it more
We make
challenging. It'd
a
be great if it was more
Come on, we
federally.
make a lot of money. There's no reason that we can't share that with to strengthen families. I knew groups. Obviously I'm a man. Yeah, I knew groups that when guys were called up to active duty. For instance, I was a reservist and I was called up to active duty, and my income dropped like a rock. I mean, like to 40% of what it had been, and it was an open-ended deployment, and I was gone better part of a year at that rate. We almost lost our house. But I knew groups that, like you're saying, jumped in and said, "You're called up by the military. We're going to cover you. Whatever the military pays you, we're going to make up the difference to be whatever you were before and make you
Right.
whole." Well, I mean, I went, where are these groups? These groups are the ones you want to work for. And the same thing is true about, women having pregnancy leave and maternity leave, to say, come on, guys, this is a natural thing. We want people to have their children. We want women in the group. We don't want a bunch of only men in the group. And this is how we divvy it up. We cover them.
Right.
And
And even giving dad some maternity leave or paternal leave. My husband, ironically, worked for JP Morgan Chase when we had our first child. He had more paternal leave than I did.
than you did.
He
Yeah.
had more time off, and he had more money than I
Jeez.
did as a mother.
Yeah.
Which
Well,
is, I mean, it's great that they're identifying that dads can be helpful at home, even if you're not breastfeeding that infant. You can help keep, you know how it is. You lend a helping hand. You fill in with the older children. But I mean, it's essential for the mom to have. It'd be great for both parents. And I just think it's funny. I don't understand why we haven't identified this as something that
no,
would really strengthen us.
you want to know the truth? I'll just say it right here. It's selfishness. It's looking at the world only from me. Because here's
Mhm.
what I'll give you the ugly side of this. Okay. When guys are looking at their paycheck and they say, well, if we hire her and she gets pregnant, my work is going to subsidize her while she's sitting at home eating bonbons on the couch and watching her little rugrat run around. Okay,
Mhm.
that's the ugly other side of this, and we need to call ourselves to be better. That's just really what it boils down
Yeah,
to.
absolutely. Because I mean, I think that having a stronger female presence in the practice of all specialties has
Absolutely.
made it so much better. If you look at medical school matriculation now, it's primarily women, right? They're a little bit more, the majority, I think, passing the 50% mark.
Yeah.
And this is going to be more of an issue because for a lot of these up and coming docs, they don't really have kids in medical school and residency. The ones that do, I mean, they're amazing because it's nearly impossible to get that done during that training time period. So, but a lot of people try to wait until they're out, and so then groups have to deal with that. But it's a natural part of the life. I think it increases the overall quality of the group and their ability to have a diverse representation with practice. And then,
And
like I
diverse.
said, there's things that I can do in practice as a mom, as a female doc with patients that other docs probably just don't do as well because of my experience.
Exactly. Diversity is not about diversity is not a political thing. Diversity is an integrity thing. It's a thing of the group. The group having a lot of different people with different strengths. And if your group is all exactly the same, you're going to be really good at some things, and you're going to really have some blind spots,
Right.
some blind spots that you probably don't even know what you don't know. Just like what I'm saying here, you don't know what you don't know.
Right.
And you by being part of our group, the University of Maryland group. Now, I don't get a chance to work with you frequently, but the times that I have, uh, you and women physicians, moms, add uh, uh, a perspective and an understanding in our group that that I don't have. I simply
Well, I
do not.
appreciate that, Mark, and I'm glad that you're so insightful. What do you think we can do to bring on board maybe some other men or just groups that have not identified the importance of supporting uh, pregnant moms and mom docs in their journey?
Well, part of the reason you saw the cover of Emergency Physicians Monthly last month, it was about this. It's part of the reason why I'm talking to you today, is because we want to start to really lift this up and emphasize it, start the conversation. And if we have to shame the guys to say, the guys, quit being a jerk,
Mhm.
and realize what the gals are adding to your group, and let's do the right thing here. Well, then I think that people will start to do the right thing. Of course,
Mhm.
there's always legislation, and I think that is helpful. Both state and federal legislation is important, but I really think it's really a change of heart. Come on, you just gotta the discussion has to occur within the group itself, and say there's more to the group than just simply the take home check. Uh, we're we're here practicing medicine not just as individuals, okay,
Mhm.
but we're practicing medicine as a group. I don't know about you, but I'm very proud to be a part of the University of Maryland group, and it,
Right.
it says something, about quality medicine. And I think that quality extends beyond just what we know intellectually. It is what we know emotionally, and how we care for our patients, and that's a reflection of how we care for one another. It's one of the things that's a little bit off, a little bit tangential to this, but one of the things that a few years back, we Emergency Physicians Monthly did a survey of the number of doctors. It was on depression, and so we surveyed
Mhm.
emergency physicians about how many people suffered from depression and had possibly even considered self harm, that sort of thing. And we were shocked. We were shocked at the number of emergency physicians who were suffering in silence,
Mhm.
and they never had brought it out, didn't feel that they didn't have a safe place to talk about it. And so there were suicides occurring in our profession. And you would think that emergency physicians would have a very, very high level of I wouldn't say levels of suspicion, but being aware of the risk for burnout leading to depression,
Right.
leading to self harm. And here it was happening within our own groups.
Mhm.
It was happening within our own groups, and we started thinking as a professional group, as a group of physicians working in this field. Pay attention to your colleagues. Pay
Mhm.
attention to the people around you, the stresses that are going on in their lives as well. Create a group culture, create a group that cares for one another, because
Right.
you're absolutely right. This is a very stressful environment. Very,
Mhm.
from the physical violence that goes on, sometimes pointed at emergency physicians, to the physical stresses. I did 25 years of straight night shifts, and they say that's like smoking like 2, 3 packs a day.
Yes. Yes.
You know,
Huge. The health risk.
the health risk. And but I'm just saying that there are things that, as a group of emergency physicians, and that's why we're talking about it on EP Talk, that as a group of physicians, we need to be caring for each other and being listening to each other in the group and saying, "Are you okay? Or
Right.
how's the leg swelling doing? Are you? Do you need to take a break? Put your feet up." Uh,
Right.
that's 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 more than professional courtesy. That's common sense. That's being a human being. That's having some integrity as a human being. Is watching out for the people you're working with. And we
Absolutely.
don't
I
put
think
you,
that's so
we don't put
insightful,
you
Mark.
on sickle coverage at night. We don't do that to you. Um,
Right. And I mean, even after you have the baby, then supporting kind of moms in their new journey is challenging. Because the second challenge after I had the baby and then trying to get the maternity leave and, trying to catch back up after I've taken the time off, is to then breastfeed, right? To be supported in my breastfeeding journey. And I still to this day don't really have a designated place to breastfeed. They tell us we can breastfeed in the break room where people would come in all the time. I found a little conference room to tuck myself away in. But the ER is kind of like a dirty place. And so it would have been nice to have a place to get away, and it's still hard to do that, to break away for 15 minutes a couple times a shift and then not feel guilty. I mean, I would feel guilty because I'd have to leave even if it was for a short period of time to get this done, but that was essential to me being a mom. And so having colleagues like you who identify that I need some extra support, and you understand and want to support me and are checking in is huge, because it's not just the physical act of doing that. It's like that I feel supported, right? And that's how our group should be. That's how we should be raising each other up. But we're really, like they say, we're terrible patients. We really do not practice what we preach. And I think in general in emergency medicine, we need to do better with that. That will only allow us to have longevity in our careers, to be better physicians, and to not reach points personally where you cannot practice to the best of your abilities because you've stressed yourself or strained and thinned yourself out so thoroughly that you really are just not a good doc anymore. That starts with early practices in the group where it's just commonplace that we are going to support one another, especially through different challenges in life. And being a mom is definitely one of those, but there are many.
Don't give me too much credit. I'm a pretty ignorant old guy sometimes, and one of the PAs in our group the other day, I looked at her and she had this apparatus on her belt or something, and I said, I didn't know you were a diabetic and you had a insulin pump. And she looked at me like, you are so out of it. She said, this is a breast pump, you moron. And and then I realized, oh, you're right. I am a moron. I really didn't know what this was. Part of it is I didn't know that you could actually wear one and continue. She was continuing to work while she was breastfeeding.
Right. These are the things we're driven to. Like,
do that. That's got to be annoying or distracting.
I mean, it's nice in that they have these nice, breast pumps now that go into your bra and they can cover. But you're actually kind of right. Like, why can't I take 15 minutes to go pump real quick? Why do I have to have this on so that I don't miss a beat? And it's because the culture expects us to just keep moving forward and to just push through it and to not complain and to not have changes. And I do think some of that has to be brought more to light. And just the mere number of women in practice will help that. But, a lot of us women are afraid to bring things up, right? We don't want to necessarily be the squeaky wheel. We don't want to complain and ask for too much. We're already trying to establish ourselves to be respected with our peers and our colleagues, especially those who have been practicing for a long time. And so a lot of times women will just not say anything, and they'll just try to come up with ways that they can continue working and continue pumping, right? So that they don't miss a beat and they appear to be strong. And I don't necessarily know if that's always the best method, right? Some of it is really that we should just sit down and revisit some of our policies that are archaic and outdated and don't support any of our health in the way that we should. And so I'm really pleased that you were able to feature in such a big way too on the cover the huge picture, the pregnant parents. But to bring that up, there were 2 other pregnant docs while I was practicing. All 3 of us were pregnant at the same time. And so we were terrified to tell management because we were afraid they were going to get, upset. Yeah. Because all of us were going to go out around the same time and we didn't plan to do that. But it was interesting that we were like, oh my gosh, what's going to happen, to the group. And fortunately, our group was really supportive and excited, but that's not true for everyone. A lot of times women are hiding their pregnancy status or, trying to minimize the demands that they have at home because they don't want to appear weak. And that's really not the pathway, right? I think I truly believe in my heart that being a mom makes me stronger, right? There's the last patient I had on my last day before I stopped working was a young mother who was pregnant. She was about as pregnant as me, 7 months pregnant with stroke symptoms, who we thought was COVID positive.
Oh my
gosh.
She
was a young first-time mom. And I could just tell that when I was in there with all my PPE, with my pregnant belly out in front of her, I was like, look, I'm pregnant. I totally understand how terrified you are right now. She couldn't talk. You know, we were getting scans. We had to like life flight her out to university.
Yeah.
And just me being that provider that was with her, that was pregnant at the same time as she was going through that, I think, you know, was instrumental to providing her the care that she needed. I understood exactly, first of all, what risks she had because I had looked it up for myself. I was
Yeah.
talking to the neurologist. I was aware of like what scans we needed to do, what we're going to do, how the COVID played in, because those are
Right.
all things I had looked up for myself. In
Right.
addition to like that emotional connection that I made with her to help her kind of calm down and be
Yeah.
able to kind of get through that experience with, you know, as much patience as possible until we figured out what was going on. And that was the last patient I had before I stopped working.
That's crazy.
And went
That's
on
crazy.
leave, but I was
I'll have to have you write a night shift on that on that shift sometime and publish it. That'd be great. You know, this is actually shifting slightly, but it's going to impact this, and that is that okay. You're put yourself now in the chair of our department chair, or even
yeah.
Jamie who does scheduling. You can imagine she was pulling her hair out when she found out that
I know.
three full-time people were dropping out, and I'm a part-timer, so frankly, I was the one that oftentimes the one picking up the slack, not at PG, but in other places. But here's my point that I want to bring out: there is some structural change that would allow more flexibility. We have encouraged
Hmm.
emergency physicians forever to credential in multiple groups, which would give people the flexibility to expand and contract on the basis of need. And
Hmm.
I think that we need to have a larger cadre of part-time people who have cross credentialed at other places that can fill this without everybody having a conniption fit when three of the docs say, "I'm sorry, we have to take 12 weeks or longer, whatever it takes," And we say, okay, well then we shift over into this other mode. But if you have a fixed group of people and a fixed number of shifts that have to be filled in a small group, and suddenly two of those people say,
Right.
I have to take off 12 weeks, the rest of the group, has a syncopal episode and
Hmm.
says, well, there went our vacation, honey, because Liz is pregnant
Hmm.
again,
Right.
and
It leads to contention, and
yeah, I mean,
that's why people
yeah,
are nervous, and that's why women, you know, are 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 feel afraid, right, to
yeah,
live their life.
yeah, they start coming to you and saying, you're not having more kids, are you? How big a family are you going to have? How many times are we going to go through this? And I think that a structural change in emergency medicine that says, let's have more capacity. Let's
Hmm.
build in more capacity so that everybody can, let's say that I'm kind of fed up and my mental health is such that I really want to take 3 months off. Okay.
Sure.
So I don't necessarily have to always be paid for that, but I'd like to be able to hold on to my space.
Hmm.
Back when I was full time, I'd like to hold on to my position and take a sabbatical or three
Right.
month or 6 month sabbatical. What's wrong with that? I think that's good for the practice. It's good for the individual.
Absolutely.
But the only way that can actually happen is if we have structurally built in flexibility and expansion capability. And in many groups, you've got to be a pretty big group in order to do that. But
Right.
I frankly think that if we would just change our ideas about, I'll credential in this group, but if I want to pick up more shifts, can I pick them up in this group? No, but you can over in that group. And if you're credentialed in that group, oh, by the way, they've got somebody who's going out for 6 months. That'd be great. I can
Hmm.
pick up some extra time.
Hmm.
So,
And I think you're absolutely right. There's,
you
and
know,
that would be great because it would, and then people might be able to engage in doing things that help them, right? Like whether it's a mental health challenge, an illness,
right,
a sick relative, or a child that someone might need to take, you know, time for. Knowing that they have that flexibility to be supported is great. And, you know, for other people, maybe they want to pick up some extra shifts. They need, you know, extra time when they're able, or there's part-time workers, you
right.
know, they're reaching the end of their career that could fill those gaps. You know, I think that's a great solution. I do think we need to start looking outside the box for these solutions because, you know, personally, I would love for there to be more of a federal support, right, for paid parental leave. And we
Yeah.
did recently have a change. Recently they did sign a bill that
Yeah.
is
That was
supporting
part of
12 weeks
yeah, that was
of
part of the tax cuts. That was
yep,
good.
for federal workers. And so the private sector might follow suit. But we are supposed to be kind of, in the ones innovating and solving our own problems and identifying how to support and grow ourselves as professionals. And so I think you're absolutely right. There does need to be that capacity growth, and it needs to be locally and readily available.
Yeah.
So not a bad idea, and these larger groups could do that, but again, it's definitely doing it across different groups and institutions, because it's going to be hard to bring someone in who's far away or just can't make that kind of drive. But
Uh,
having a bank of people that can
Pride.
absorb that,
I lived in Delaware and
gap
worked in Texas and Missouri and Illinois and everywhere else, for 25 years. So I think that we just need to look more broadly. The thing that we have to realize is that many of us, the specialty, actually one of its pillars was the fact that you could have a career flexibility. That's
Mhm.
one of the attractions of going into
Right.
emergency medicine, as opposed to a cardiology practice or a surgical practice where you've got to be there every day, every day, every day. If you can't be there, then your practice evaporates. And
Right.
one of the things about emergency medicine was the ability to step in, to work, and then to go home. And then what happened over the last 25, 30 years was the emergency medicine kind of fossilized. It crystallized into these large groups where people dare not step outside of that, and the flexibility started to be diminished in a lot of in a lot of capacities. And I would really like to, as women, get more and more. Women may eventually be the majority in emergency medicine. I think that a lot of
Mhm.
programs are majority women, and I think that one of the real benefits of having women as a real structural impact players in emergency medicine is we may actually get back some of the flexibility that we all came into this practice for.
Right.
The idea that young emergency physicians come in and they've been knocking themselves out for 15, 18, 20 years to get where they are, and they get here and they go, am I going to be doing this again for another 20 or 30 years, or could I actually have some flexibility? And I think
Right.
that maternity leave is actually just one part of what we should be doing structurally to emergency medicine that allows everybody to have some ability to do something new, take some time off, take a sabbatical, get your head clear, you know,
Right.
uh,
Or a lot of
recover.
us, tend to have outside interests in emergency medicine. We tend to attract very dynamic people who have like multifaceted careers. Like for me, I'm very interested in policy, like you.
Uh-huh.
Most recently, especially with the COVID pandemic, it's really brought to the forefront how important I think advanced care planning is. Just from my personal experience, and then what we're dealing with patients. And so I've had some opportunities to kind of work on that from a policy perspective and kind of pick that up, but I don't know how to maintain that and keep doing all this clinical work. And it would be nice if there was a pathway to continue,
Yeah,
that I could still be growing my academic and clinical career, but engage in this other interest in a meaningful way, and it was cohesive and flexible so that everything prospered at the same time. And that is why I went into emergency medicine. That's for a lot of us. We
exactly.
you're also someone who I know ran for office, and we are definitely passionate about those problems that affect greater kind of public health issues in government. And that's because we see those issues every day at work, but I have to be able to have the flexibility to act on them. What did
Yeah.
you do when you were running for office? You still, you couldn't do everything at the same time. Something had to give. It would be nice if that was built into the practice of emergency medicine. We would then attract even more of our best and brightest docs to the practice, because we were, the specialty that allowed people to engage all of their interests and gave them the tools to excel at everything at the same time. And I think you'd see more longevity in the career, right? Because you wouldn't be
Exactly.
burning out at any particular aspect.
That's exactly right. One of the things that, again, I'm steering off of this the maternity question, but one of the things that I have really tried to encourage in EP Monthly is the idea of innovators. and entrepreneurs and inventors and people like that who are looking at with a fresh eye at a problem and trying to fix some of the problems that we see. And emergency medicine was really one of the first specialties, was the first specialty that really looked at delivery of care and how to make it accessible to everybody 24/7, 365. That was an innovation. Those guys back in the late 60s and 70s were innovators. Okay. And now we've got other people who are doing the same thing, who are tackling problems like yourself, talking about policy issues. Maybe they're making an innovation or an invention, how to do various things. Those are things that we as emergency physicians want to encourage.
Right.
We want to encourage it. And so the only way that that's going to actually happen is if we have a structural flexibility that says, hey, you want to work 3/4 time, you want to work 20 hours a week, you want to work 15 hours a week, we can handle all of that.
Right. It's so ironic that you brought that up, because I actually think you don't know this about me, but I actually am an innovator. So I came up when I was in residency with a novel epistaxis device that I call Bleed Freeze.
No, it's actually, we talked about this one. Yeah.
Yeah, and so I went to I-Corps and literally right now, while I'm on my maternity leave, because I couldn't find any other time, I just was awarded the TEDCO grant. It's for the Builder Fund. So it's like pre-seed state program that gives me a little bit of money by executive coaching to try to get my medical device startup off the ground. And I'm literally on conference calls with like my newborn infant on my chest, because I'm like, all right, I got to use this 12 weeks that I have to get this done, because I want to drive my business forward. And this is the opportunity that I have to do it. But I don't really feel like I can do it while I'm working full time. So I'm using this time while I'm on maternity leave, which is not great, right? Like, it would be nice if I could use that time to just be a mom. But because I have this opportunity with this medical device to get it off the ground and this new financial support and coaching that I'm getting, I want to kind of put the pedal to the metal and see if I can make that successful. And there are so many docs that have innovative ideas when it comes to medicine, because we, again, we see all the things that fall through the cracks. And then a lot of these younger trainees are looking at problems with fresh eyes and are like, why do we do things that way? What can we do about that that's different? And you're absolutely right. We should support them in that. That is how we will rise to the top of having the best medicine, the best technology in the world, if we give space for innovation. But there has to be the financial, mental, and physical space for that to grow. And right now it's not built into the career. So you have people like me who are, kind of like on all the time, using, all of my capacity when I'm on, break, to do policy stuff that I'm interested in, to teach when I can, to practice because I got to pay the bills, and then, do this other thing with my business because I think, in the long haul, that could be really successful. So I think that I'm exactly the type of doc that you're talking about that would be benefit from having support and structure within the practice of emergency medicine that allows me to flourish with all the things that I want to do.
Yeah, exactly. And I think that the irony of that is that one of the things that the COVID contraction, I don't know, all of our EDs dropped off dramatically with our patient volumes, and we cut shifts, and suddenly there are people who don't have hours and that sort of thing. One of the things that if there's anything this has taught us, and that is that if we have a fossilized idea about the way emergency medicine is practiced, that we are vulnerable. We as individuals are vulnerable. And yet if we as emergency physicians and entrepreneurs and thinkers and inventors and people with secondary interests and stuff develop ourselves, not only are we personally broader and more fulfilled and more contributing more to society, but we also have resilience, that kind of resilience that is able to weather big changes like this. Suddenly, we have 20% less shifts, and suddenly, what do? You fire 20% of the docs. You contract back. Well, if you've got this capability in the specialty itself all the time, you have people that's not going to really kill them. They take on other things. They do other things. They've always been doing other things. And
Right.
so I think that that's part of the DNA of what an emergency physician is about. That's probably what attracted you to emergency medicine. It's what attracted me to emergency medicine, was the idea that, well, I went to law school, and I, started a publication, and I did some other things, and I did all that, and I was only able to do it. I'll be honest with you. I was only able to do it because I worked full-time locum tenens. I was the independent guy. If I wanted to work 80 hours a week, I could work 80 hours a week. If I wanted to take the summer off, I took the summer off. I personally think everybody ought to have that kind of practice. It was great. And I don't understand why people are locked into these groups that have a fixed idea. Okay, you're a mom, you got 2 kids, you want to be with your kids, you still have to work 40 hours a week. Well, no, you don't. No.
Right.
I want to start a business on the side. I want to start a publication on the side. How much do you want to work? Well, let's put how much I want to work.
Right, and have that flexibility built in.
Yeah.
Well, I think we need to talk to some of the leaders in our specialty, and I would consider us to be some of those leaders. So we need to circulate among our colleagues and talk to some of our professional organizations, because I do not think this is an uncommon view, right? I think a lot of other docs would absolutely agree with what we're saying. But I'm all about taking action so things can actually move towards that direction. I believe that this pandemic is going to really force a lot of groups and even individual physicians to just stop and reflect on how they're practicing and what their life is like and structured, and what flexibility is going to be needed. And who knows what's going to happen in the future, right? This winter could be really crazy.
Yeah.
And we might need then all hands on deck. And, there's just going to be so many unknown variables moving forward. And the strength of emergency medicine always has been its flexibility. And so I think anything that we can do to move against that crystallization and fossilization that you spoke about in the practice that has not benefited us is something that we need to have a larger conversation about so we can have real change. So, I'm sure you and I can talk to our group leaders, and it does start with small conversations. But, for anyone else that's listening, if they agree, I think if we get a consensus, a group of us, a small majority that thinks that this needs to happen, then we can find the actual structural tools to implement that and make it a reality for practicing docs.
You want to know the truth? I think that you're always looking for champions. When I think that I have an idea that needs to be put forward, you have to have champions. You have to have people who have skin in the game, who see the purpose and want to see it succeed. You want to know who the champions are in this? Are women. Women.
I agree.
Women who are like yourself, who are having children and are saying we need to have real, honest flexibility in our careers in order to be fulfilled and to be the best we can be. And I think that the whole idea of maternity leave and leave for personal development are tied together. But the real champions, the people who really have the skin in the game, are moms. Emergency physician moms who really see it, and they're faced with it every day. So let's start there and see where that takes us, because I think it takes us far beyond emergency physician moms. I think it takes us to a real fundamental structure questions about our profession. But I think that this particular question, emergency physician moms, is the test case. Can we treat moms with integrity and reason and fairness, and can we promote them being the best they want to be? And if we do that and we start getting those principles and we start expanding out and doing this with other people, then the practice itself will be fundamentally changed for the better. So thank you.
Absolutely. Well said, Mark. I couldn't agree more. So all those other mom docs out there, I know there's like Facebook groups and other ways that we communicate, but we need to come together. We need to band together, and we need to make change.
Let's push this out. We'll push this podcast out to some of those groups and try to get some feedback and some champions to feed into this. That'll be great.
Absolutely. I'd be happy to talk to whoever is interested in, the number of things that we talked about today. And I do appreciate you having me on and for taking the time to highlight this important issue.
Cool. Well, thank you, Liz. It's great talking to you. And for all of you who've been watching today, EP Talk, thanks for joining us. And I'm sure that there will be a lot of comments and questions, and I hope that you'll jump on board with this, because this is a pretty, it goes far. The point is, it goes far beyond moms. It starts there because that's a fundamental question, but this whole idea goes far beyond it. Every single emergency physician has skin in this game. So I hope you've enjoyed this discussion, and I hope you push it out to your friends. So thank you for joining us today. Take care.